Hartnup, autosomal recessive. Take a look. Impaired transport of tryptophan, Hartnup. And other neutral amino acids. What are these? Well, at least have a couple in mind, like such as leucine, isoleucine. Now stop there for 1 second. When this is an inherited disorder, it means that anywhere in the body that you're supposed to take up that particular substance, you cannot. So, not only are you not able to properly reabsorb tryptophan from the proximal convoluted tubule, take a look please. You cannot take it up from the small intestine. Now, both of these are then going to give you interesting issues. Let's do the kidneys first. If you're not able to properly take it up from the kidney, then there goes the tryptophan. Guess what you need tryptophan for clinically, so that sometimes you know so much. You do. You know so much, but then you have to organize your thoughts. And you can come up with all kinds of combination. A lot of times, it's about seeing the patient, in which it finally tells you, oh, that's what's going on. For example, we all know about tryptophan, and we all know that it's part of 5-HT, 5-hydroxytryptophan. That's serotonin. Let it go. Please let that go. What you truly need here to clinically diagnose your patient with tryptophan is that tryptophan is also a precursor for niacin. Aha! And that's how your patient is going to present. Are we clear? So when you talk about Hartnup, first and foremost, your focus is on tryptophan. Next, tryptophan, you want to think of it as being a precursor for which vitamin? Well, this is going to be vitamin B3. What's B3? Niacin. Now, you know, or you should know, when you have niacin deficiency, what's the name of that disease? Pellagra, right? Pellagra. And when you think about pellagra, what does that mean to you? What letter comes to mind? D. Mean to say dementia, and dermatitis, and diarrhea, death. Hold on to everything that I just said. I'm going to reinforce this on the next slide. Now, amino acids that are then retained in the intestine. Let me finish this real quick. In the intestine, change gear, you're not able to take up tryptophan. That's a problem. So that tryptophan remains within the intestine. Guess what it turns into? Take a look. It turns into a neurotoxin. Unbelievable that this patient will have CNS toxicity. So what kind of things are you looking for in your patient? Tryptophan is the precursor for niacin. Stop there. The fact that you have niacin deficiency, now, is this complete official pellagra? No. It's the fact that tryptophan is missing. So you'll have components of pellagra. Which is the most important component? It's the dermatitis, the pellagra-like eruption, and photosensitivity. Are we clear? Along with neurotoxicity, and you're thinking about tryptophan, no doubt, clincher diagnosis is going to be Hartnup. You bring into play the kidney, you can't take up the tryptophan, niacin, pellagra-like issue, especially the dermatitis and photosensitivity, and neurotoxicity, you cannot miss this diagnosis. Let's move on. Now, with Hartnup, we have most patients are asymptomatic, pellagra-like skin eruption. Take a look at this patient here. You see that skin? That's the photosensitivity and pellagra-like eruption. The skin. What else do you think this patient is feeling or expressing? Maybe, perhaps not, because they might have neurologic deficit. They might have cerebellar ataxia, psychiatric symptoms, skin issue, neurotoxicity, high in a differential, Hartnup. Are we clear? And how do you confirm this? I'm going to lose tryptophan from the urine. How could you miss this diagnosis? You have gross amino aciduria. Are we clear? So now be careful with the term amino aciduria, correct? A few differential. Let me give you another one. There's something called subacute combined degeneration. Now pay attention here. You know this. Subacute combined degeneration. That also gives you cerebellar ataxia, but that'll give you MMA, methylmalonic aciduria. So what's that neurologic deficit being caused by? B12 deficiency. B12 deficiency, you have methylmalonic aciduria, and you also have megaloblastic anemia. So you're at a point, ladies and gentlemen. Now we're doing pathology. No joke. This is medicine. And your job, so that you are to be highly successful on your rotations and on your boards, is make sure that you come up with 2 or 3 differentials for many of these symptoms as possible, and then you clearly distinguish one from the other so that you're not just compartmentalizing. We cannot do that anymore, and we haven't been, okay? This is amino aciduria, skin infection, neurotoxicity, Hartnup. Let's continue. Now we have cystinuria. Right off the back, I want you to take a look at the green box. And we have a nice little mnemonic there. It's called COLA. Autosomal recessive, you cannot take up your cysteine, ornithine, lysine, arginine. Your focus should be on cysteine, a dibasic amino acid. And this may then predispose you to cysteine stones. So the other time that we will repeat this is when we get into kidney stones, okay? Now, with the cysteine stones, you end up on urine analysis forming these beautiful crystals. They're hexagonal. It is unreal. It really is. One would think to yourself that I actually feel jealous that I can't form such crystals in my urine. Don't be, because this is a patient who's not able to take up cysteine and maybe perhaps some of these other amino acids. Where am I? PCT. Recurrent renal ureteral bladder stones. 24-hour urine collection. Take a look at this cartoon. You will form clear hexagonal crystals, colorless.